this class right now. So you'll give him your undivided attention, okay? And remember, this is our safe place, so if you have questions, you raise your hands, okay? No jibber-jabbering, same policies apply, no texting, all that stuff, okay? All right, Mr. Money, to advance your slides here, just a minute.
Okay.
That's it. I've already got it. What's in presenter mode here for you. This is not what they see this way.
Okay.
So this helps you see where you're at and pace yourself, okay? All right, so undivided attention, get your notes out.
All right, so good morning. I am, my name's Nick Money. Some of you guys I've had in clinical, some have kind of seen me hanging out with you guys. So we will be talking about chest tubes as a whole, in addition to your module B. I believe some of this information may be on your exam, so
It will be.
I've tried to put something together that may be a little more wordy than what you guys are used to, but I wanted to make sure that I covered a good portion of it as we talk about it. So, learning objectives, like with every PowerPoint you guys look at, we're going to identify the anatomy of the chest cavity that is relevant to the chest tube placement. Describe the equipment needed for insertion of a chest tube, which we will not be doing specifically. That will be your provider. You may assist with it, so it's good information to know. We're going to review the indications for a chest tube and explain the structured interprofessional team approach to provide effective care to and appropriate surveillance of the patients undergoing chest tube placement. So, mouthful. So what is a chest tube? We also call that insertion a thoracostomy tube. You don't really see that too often. Your doctor is going to put in a chest tube, they're going to call it a chest tube. So it acts as a drain. The chest tube is inserted through the chest wall between the ribs and into the pleural space to remove either air or fluid. Fluid could be purulent or blood. In the picture here on the left, this is actually what you're kind of look at, and it actually looks like it's taped on all four sides. It shouldn't be, but this was a pretty good illustration of what it's going to look like. And then on the right there are your assorted sizes, depending on the size of your patient. We have pediatric chest tubes as well, so the appropriate size is going to matter in this situation. So, relevant anatomy, you got a picture of the right lung, so you've got your pleural membranes, which is that light purple peak towards the outside. You've got your pleural space, which is where your chest tube is going to be inserted into. Positioning depends on where the location of the pneumothorax is, or the hemothorax. You got your ribs there that you're going to go through to the intercostals, and of course your diaphragm down here. Lots of information going on the screen. It's not super pertinent that you get every one of these. If you're writing, you don't have to write all this down, and I'm certainly not going to read every one of these. Yes, ma'am.
I'm going to post this in the course, so you'll have it. Okay, I will upload it in the course after today. I didn't interrupt you, Mr. Money.
Oh, you're fine.
I will post it, you'll have all this in your course, okay?
A lot of this stuff can be a bit redundant because typically when you're going to assist a physician with the placement of a chest tube, this is probably going to happen more commonly in your ER setting, maybe even in your ICU setting, and I've seen it like twice in 10 years happen on the floor, and usually in that situation it's an emergency. So you're going to have a kit that is prepackaged from the manufacturer that's going to have almost everything that you need in it. So finding each one of these items individually is not going to be something that you're always going to have to do. And these kits come with the certain size chest tube. So if you're going down to your purchasing, like at Flowers, I'm not sure what they call it at Southeast, you're going to have someone in there that you can tell them what you need, and for the most part they're going to be able to kind of find it for you or direct you to the right area. So why we would need a chest tube or indications for such. The insertion of a chest tube is usually performed by a physician. I do believe advanced practices can do this, PAs and nurse practitioners who are supervised or governed by an overseeing physician. They can be indicated in an emergency situation and non-emergency situations. Pneumothorax for air, hemothorax for blood. Fluid collections can be from a pleural effusion. You don't see that too often. I mean, if it's really, really nasty, you may see a chest tube inserted for pleural effusions. And then, of course, you got your empyemas, which is kind of a rare thing. I mean, it's not super rare, but you've got a purulent collection of fluid within the vagina. Other indications, chest tubes can be used for the removal of the fluid or air in order to reestablish negative intrapleural pressure and to re-expand the collapsed lung. For the removal of air, depending on what type of situation you have, will indicate where the chest tube is inserted on the patient. So for the removal of air, you would insert the chest tube at the second or third intercostal space, and for the removal of fluid, so we talked about in class the other day, fluid is heavier, so it goes down lower. You're going to insert that tube at the 6th, 7th, or 8th intercostal space. So, managing a patient with a chest tube, there are 3 types of managements. We've got suction, water seal, and clamps. And then, of course, we've got different types of systems. We've got a Pleurovac, an Atrium, and an Emerson. If you're at Flowers or Southeast, you may can weigh in on either side. The one on the bottom right there is your Atrium. This is what you're typically going to see at the bedside. I've never seen the Pleurovac. Maybe some of you have. And the Emerson is a dinosaur. If you see these, it's probably a last resort. I've talked to a couple of our folks at Flowers, and no one as young as me has seen one of these in practice, but they are still out there. Yeah, you can just look at it and tell that it probably belongs in. It actually says Copyright Museum of Healthcare. It belongs in.
I can tell you that made me feel antiquated, because that's the system we used when I first went through. It had 3 bottles in the bottom. 3 glass bottles. I still have one of those bottles in my office.
Now, it's funny about those bottles is if you have a patient, this is slightly on a different page, but if you have a Pleurovac drain that's placed in that pleural cavity to help them remove fluid intermittently at home or in a home health setting, you'll see those bottles. I don't think they work very well. I mean, that's what they have at home, but you may actually see that in practice. The management of the chest tube therapy. Suction is not always required and can actually cause tissue trauma and prolongation of an air leak. The water sealed chamber, sterile water is added to the approximately 2 to 3 centimeter line. It'll actually be labeled on that atrium, and that's kind of what I'm going to reference. This is what I'm used to. The physician will place the order for the desired suction pressure, usually negative 20 centimeters H2O. Secured connection areas with Durapore or microfoam tape. So you're talking that the sponge tape, or I believe Durapore is the silk. Is that silk tape? I think it's silk tape.
Yeah, you want it to be as occlusive as possible.
That's right. And the occlusive dressing is secured to the chest tube site and is assessed comprehensively every 2 hours. Or your hospital policy or wherever you work. I believe in the ICU setting, if you're going to have a chest tube, you're in that room all the time anyway, but every 2 hours is the absolute necessary. Sterility is absolutely essential when managing and changing the dressing. You'll want to retrieve a new drainage system once the system that you're using is full or if it becomes knocked over. The liquid and the fluid that are in these things have their own separate chambers where they belong. So if this thing gets tipped over, you may have blood mixing in with your water. It's going to look like a nasty mess, and that's what you have to do, is you have to replace that system. You want to ensure that the drainage tubes are not obstructed or occluded. You're going to place the drainage system out of traffic areas. So obviously if you've got your patient bed, you're going to want that below the chest level, but you're going to want it kind of towards the head of your bed. You're going to want it in where you're going to be walking. You don't want to set it near a trash can that's going to get bumped. But you also don't want to place this thing under the bed, because if you're raising and lowering this bed, those beds will crush this thing, and then you're going to have a big mess. So make sure that you place this chest tube system in a very safe place that will not be tipped over. Never strip the chest tube. You should check your facility policy on milking of the chest tube. Those are 2 different terms. if this is going to happen, I've seen physicians do this, but it's usually a sworn no-no for nurses. So I want to make sure that you definitely check into your policy for how you manage that type of situation. Emergency supplies to the bedside, your sterile connectors, your sterile petroleum gauze, and your padded clamps in case of dislodgement, which it can happen. It could be a serious situation. So, make sure to stabilize the drain near the skin. This was a drain stripping. I only threw this up here so that you could see what it is, not to do it. So let's see if this thing works.
Hope it will since I updated.
It should.
Player.
There's no sound to it.
Perfect.
So they grab real close to the patient and they secure it, holding it tight, and then stripping is literally just pulling down on it. They use that alcohol, an alcohol prep pad to kind of sort of decrease the, I thought it was there to kind of clean the tube, which I guess it helps with that too, but it decreases the friction when you're pulling on it. So
Why do you
yeah.
think, I'm sorry, Mr. Money, why do you think we can't strip chest tubes? What is it, what's happening in the pleural space when that tube becomes clamped like that, essentially? You're increasing intrathoracic pressure. That's
That's right.
exactly right. You can cause an pneumothorax, okay?
Absolutely.
Thank you, Mr. Money.
Yes, ma'am.
Just let you advance. It does that sometimes if it has that media player. Let me get it where it will, at least it let yours play today. Did you get it? Yeah.
Maybe. Yeah, let me go back. There it goes.
Okay.
All right.
It did.
So the water seal, we're talking about fluctuation and titling. All the research that I did when I was putting this together kept going back to NCLEX. So if you get to your NCLEX, which you will, you're going to be looking for key words, and fluctuating and titling are going to be some of those key words. So this should be noted in the volume chamber with normal breathing and coughing, maybe even a sneeze. Hopefully you won't have that. Identify constant or intermittent bubbling, which is an indicative of an air leak. So those two terms there, constant or intermittent bubbling, can be a problem, usually an air leak. Could be external or internal in nature, and what we mean by that is if it's external, obviously it's outside the patient. It's going to be between where it connects to the patient and your atrium or your management system. So either one of your things are clamped off, you get the little square rings that clamp, or maybe it's become dislodged from the system. If you're talking, and of course right there, obstructing tubing or the kink, ensure that the patient is not laying on the tube. Sometimes if you're turning your patients, it's a big tube, it looks like a big water hose. It can get up under them, so you want to make sure that it's not obstructed that way. Malfunction of the management system, disconnection from the device management system. So if your chest tube comes dislodged from the top of your atrium, that's what we're talking about for an external factor. Internal issues can be slippage of the tube or an internal obstruction, which is usually caused by clots. If the issue cannot be corrected at the bedside, this is when you're going to notify your physician. Not before, because you have to use your skills at the bedside to try to determine what's going on. If you call, I'm not even sure who our surgeons are at the hospital, but if you call them and they come up there to look at it and they find that the patient's laying on it, it won't be a good day in that room. So the takeaway for your water seal, the water seal therapy allows for fluid or air to escape from the pleural space, but prevents air from re-entering your pleural space. Consistent bubbling while on the water seal means possible air leak. Maintain the sterile fluid volume. Evaporation can occur, so whenever you open up your new atrium chamber, usually it comes with its own sterile water to instill into that, but this water can drop over a couple of days, so you may have to add more to it. And never, ever, never clamp your chest tube. That's usually going to be your provider doing that for you. I know that whenever they are considering removing a chest tube, I know his name is Jason. I don't know, Jason Cox. He likes to come in, he likes to clamp the chest tube, he will actually remove it from the atrium, and he will tie a little knot in it. So you're at Flowers and you come into your patient's room and you see that, that is a signature characteristic of him disconnecting your patient from.
Is that the nurse practitioner?
He's a PA.
He is a PA.
Okay, yeah, I seen him when they removed it
Yep.
in clinical. I seen him do that.
If you're ever with them, he is he likes to show a tale. So if you're ever with him, he will explain it to you and give you a little rundown on exactly what he's doing. Complications, you can have some subcutaneous emphysema, which can occur immediately and normally on insertion of a chest tube. It's described as Rice Krispies under the skin. If you've ever felt it, it kind of gives and it sounds like Rice Krispies, and it feels that way too. It's trapped air under the skin, and this finding should not grow or migrate to other areas of the patient's chest. If you have this situation, you can mark these areas with a skin pen or even a permanent marker, whichever you have available to you, and you monitor that. Disconnection or dislodgement from your patient, which is considered an emergency. We're talking about the tube coming dislodged from the actual patient, not necessarily your management system. You want to advise your patient to forcefully cough and exhale. Once that happens, you're going to apply that petroleum occlusive dressing to the puncture site, and you're going to secure it on 3 sides. Usually, you're either going to do it on both sides, but left and right in the top. But I've also seen bottom, depending on where it's on your patient, bottom left and top, so that you have that, because you want it to be loose where your tube can come out. And we tape it on the 3 sides so that we can allow air to escape on exhalation. There can be serious consequences for taping on all 4 sides. You can develop a tension pneumothorax, and then you can have even further and more severe complications, even death.
Notice you got that in all caps there.
Sure. So damaged device management systems, this can actually happen quite often. Knocking them over is probably the most common situation. Usually you're not going to have a system that's damaged when you open it. I mean, I guess that's possible, but if this happens, it's very simple. You remove your tube from the damaged device, not your patient. Remove it from the device, and you're going to insert the distal end of that tube that you removed into sterile saline. If the distal end is inadvertently disconnected from the device management system and is not contaminated, you can simply clean it with alcohol and reconnect. That's if there's no damage to your management system. So your management takeaway, no milking or stripping of the tubes. And milking is not as bad as stripping. You're essentially trying, because if you get some fluid, blood or whatever caught up in that tube, you can kind of help facilitate it down, but definitely no stripping. No clamping of the chest tube. Continuous or vigorous bubbling is problematic. Ensure that you are securing the drainage management system out of the way of traffic, and make sure that you have all of your emergency supplies to the bedside. Wow, I'm at the end of it. So, if you didn't learn anything from me, this guy, I looked at a lot of videos, and this guy, and I hope it works, did a really, really good job. It's about a 10 or 12 minute video. He definitely encapsulates everything that I've said, and even more so, because you actually get to see things going on here. So let me see if I can talk fast when I'm nervous.
Is it functioning for you?
I'm clicking it.
Okay.
It's not working.
Now for chest tubes. As you know, chest tubes are used to drain fluid, blood, or air from the pleural space within the lung in order to re-expand a collapsed lung. And so the main purpose is to restore a normal negative pressure within the pleural space. Like with a pleural effusion, where we have fluid in the pleural lung space, or a hemothorax, that blood in that pleural lung space, and even pneumothorax, that air inside that lung space. Now, how does a chest tube work? Well, by inserting the tube into this pleural lung space, it simply sucks out that air, fluid, or blood into a closed, one-way drainage system. So naturally, we must keep the drainage system below the chest level to help with drainage. So Hesse mentions this, asking interventions for a client with a chest tube for a pneumothorax. And the answer is to keep the drainage below the chest level. Yes, gravity helps with drainage. Now for chest tube care, the 3 chambers to know for your nursing exams and the NCLEX is, number 1, the suction control chamber right here. Number 2, the water seal chamber that also has an air leak gauge right here. And third, the collection chamber to measure output. So starting with number 1, the suction control chamber. Key terms here, write this down. We want to see gentle, steady, or key terms, continuous bubbling. This means we have a good amount of suction being applied, especially with clients with a pneumothorax, that air inside the lung. Again, gentle, continuous bubbling means the chest tube is working, not vigorous or violent bubbling. This means that the suction is too high. So the memory trick we use, just think of a child sucking down a milkshake in the suction control chamber. We want gentle, continuous bubbling, not vigorous or violent bubbling, just like the milkshake. Vigorous bubbling is not good and could get a little bit messy. Next, we have the water seal chamber and air leak monitor. This guy acts as a one-way valve to help drain air and fluid from the lung, and also prevents air from entering that chest cavity. Now, it's good to see a steady rise and fall with breathing. This is known as tidling, and this is good. It means that the system is working correctly and keeping that negative pressure, naturally rising and falling with each breath. And this will naturally reduce as the lung re-expands. Now, continuous bubbling is very bad. Typically, it means that there's an air leak inside the system. Oh no! But we'll cover this more in detail in a moment. So the memory trick, just think of a seal inside the ocean for the water seal. This seal floats up and down with the tides of the waves, nice and even every time it takes a breath. So this is tidling, that rise and fall with the tide. Now a big no-no is we never want this seal to be blowing continuous bubbles under the water. So just think of a lifeguard saying, "Hey, no bubbling in the water, you seal." Check out our brand new app and get access to our new pharmacology and med-surg mastery courses, plus 11 other courses like fundamentals, pediatrics, maternity, mental health, and more. Complete with over
I think it's an
300
ad.
follow-ons
YouTube loves ads these
and a
days.
massive quiz bank loaded with detailed rationales to test your knowledge. Join for free. Click the link in our description below. So that's how I remember no continuous bubbling in the air leak chamber of the water seal. Now, Kaplan mentions, what is the best response by the nurse when a client is asking about tidling in the water seal chamber? The answer is, it shows your lung has not yet re-expanded. And ATI mentions, possible indication of lung re-expansion, well, tidling in the water seal chamber has stopped. Yes, this could mean lung re-expansion. So if we no longer see this tidling, those fluctuations up and down, again, it could mean 2 things. Either the lung has fully re-expanded, as ATI stated here, which is good news, and we can remove the tube. Or the bad news, we don't want this. It could indicate that a blockage, like a blood clot, is stuck in the tube, or maybe there's a kink somewhere inside the tube. So Kaplan mentions, monitor for fluctuation in the water seal. No fluctuation may indicate a blockage. So write down these key words. They use fluctuation instead of tidling. Basically the same thing. So no fluctuation may indicate that blockage. Next we have the air leak monitor, found right here near the water seal chamber. Now the NCLEX loves to ask about the location of this air leak gauge. So write down and know this location. Now, what do you think the air leak monitor does? Well, Do you think it might monitor some air leaks? Well, yes. So the key point to write down is not that. The key point here, once again, is continuous bubbling is bad. This key term means we have an air leak, and air leaks are not good here. There should be no continuous bubbling in the air leak chamber or the water seal. So just think, it should not look like a hot tub in there. No hot tubs and no time machines. Now, intermittent bubbling that comes and goes is perfectly normal. That typically happens when you sneeze or if the client coughs. Now, third, the collection chamber. This helps to drain the fluid as well as the blood from the lung. We assess this chamber every hour for the first 8 hours from insertion, then every 8 hours after that. Now, the key numbers to know of when to notify the HCP, write this down, it's always on exams. Bright red blood over 100 mLs per hour after the first hour of placement. Now, the key term here that you have to focus on is bright red blood. Worry about the bright red, since this means active hemorrhage. So just think, if the blood is bright, then something ain't right. We must notify the provider, especially after surgery or new insertion within the first 8 hours. Now, don't let the NCLEX trick you here. We do not clamp the chest tube. This will only back up heavy drainage and make pressure in the lung cavity worse. And if we see bright red blood, we do not give pain meds as the first intervention. This obviously won't stop the bleeding. So we must notify the provider first with that bright red. Okay, now switching gears, what happens if the blood is dark red? Again, don't let the NCLEX trick you here. Just think D for dark bloody drainage is normal. So we D, document and monitor, since it's old blood. Say you're turning a patient 2 to 3 days after surgery, and suddenly about 200 mLs of dark blood drains into the collection chamber, like all of a sudden. What do? Do you freak out and call your own mama? Well, no, it's not bright red blood, it's dark blood. So we know that it's old blood. So again, just think of the double D's here. It's dark blood, so we just document. And don't be alarmed with the amount of this dark bloody drainage, since it's a few days after surgery. So remember, timing and color are everything with these drainage questions. Again, our memory trick, just think, dark blood we document, since the blood is old and it's probably been there for a few days. And with bright blood, well, that ain't right blood. So, especially within the first few hours of placement, it's new and fresh, we must notify the HCP, that provider. Okay, now what do we do for stopped or decreased drainage? Say the patient has consistent output for the entire shift, and then all of a sudden, a few hours ago, the drainage stops. Well, question for you here. Do we assess the patient first or the chest tube first? Well, always assess the patient first and machine second. That's always on the NCLEX and exams. So write it down. We assess the patient first by listening or auscultating lung sounds. Now, we do not want to hear diminished breath sounds because that is a priority. This indicates that the chest tube is not working to improve that airflow, and typically means that the patient is now filling up with blood or fluid. Very deadly. So write it down, diminished breath sounds are priority. Second, we turn cough and deep breathe. And third, we reposition the patient, since blood or fluid can collect in one area of that lung space. And if the patient's been laying down in a certain position for too long, blood or fluid can collect there as well. Now, Kaplan had a question about this, asking about priority for a client with 3-chamber chest drainage system for hemothorax. And the answer is to assess the client's respiratory status frequently. Remember, we assess the patient first and then devices later. So don't let the NCLEX trick you here. We do not adjust the suction. Technically, we need an order for that. And don't assess the chest tube initially. A lot of students get this wrong on their NCLEX and exams. So write it down and know it. We always assess the patient first, before machines. Now, as far as general patient assessment, we do rounds every 2 hours. We always listen to breath sounds and check the drainage around the chest tube to see if any blood or pus from infection is there. Now, a big one here is subcutaneous emphysema, that trapped air under the skin. Sort of feels like Rice Krispies underneath the skin. Snap, crackle, and pop. Now, this is normal and to be expected on insertion, but here's the key. It should not be growing in diameter. Typically, we mark the patient with a marker to make sure this crepitus is not spreading. Okay, now for the complications that you will be tested on. So write these down. It's the 2 Ds, disconnection and damage to the chest tube. So what happens when the chest tube itself gets disconnected, cracked, kicked, or even body slammed? Body slammed? Well, yeah, anything can happen. So starting with disconnection from the patient. This typically happens by accident, so we must tell the patient to cough and exhale immediately to prevent air from rushing into that pleural space, causing that deadly tension pneumothorax and collapse in the lung. We basically have a hole in the chest here, right? In essence, we've created a sucking chest wound. So Hesse mentions interventions for a client with a chest tube for pneumothorax. If the tube becomes dislodged, ask the patient to cough and exhale as much as possible. Yes, this prevents air from rushing into that pleural space, and then immediately we do number 2, which is apply occlusive petroleum gauze dressing and secure on 3 sides. Not 4 sides, but 3 sides. Now, don't let the NCLEX trick you here. 3 sides only. This allows air to escape upon exhalation, basically when we breathe out. So the memory trick, only take 3 to let the air free. A lot of students get this wrong and choose to take 4 sides, which does not allow air out. So pressure can build up inside the chest, causing that deadly tension pneumothorax. Basically so much air pressure that it can push all the organs to one side, even the trachea, that windpipe, and eventually collapse the good lung. Now, Kaplan mentions essential equipment to have at the bedside of a client with closed chest drainage system. We have to have a sterile connector, sterile petroleum gauze, this is our occlusive dressing, as mentioned in other question banks, as well as padded clamp. So write that down, sterile petroleum gauze or occlusive dressing. Now, if the chest tube gets disconnected from the collection chamber itself, well, we have 2 options. For disconnection or damage to the drainage tube, if it's without contamination, then we use an aseptic swab and just simply reconnect it. Now, if there's damage to the water seal itself, resulting in draining all the water out of the seal, then we must place the distal end into sterile saline or sterile water. So once again, write down the key words. If the water seal chest tube is damaged, we place the distal end into sterile saline. And a little side note here, we never clamp the chest tube. This is only done a few hours before the removal or changing the drainage device. Clamping the chest tube prematurely can cause a deadly tension pneumothorax, which again can push all the organs and windpipe to one side. Now, speaking of chest tube removal, it's critical to tell the patient these key words. Take a deep breath, hold it, and bear down. That Valsalva maneuver. This is done while the tube is being removed. So write that down. This prevents air from being sucked back into the pleural space, causing that pneumothorax, air inside the lung space. Again, we must take a deep breath, hold it, and bear down. Bear down. Not a slight inhalation, but a big one. Then we typically take a chest x-ray afterward, just to make sure there's no new air or fluid inside the lung space. Now for the big no-nos, we have 3 here. Number 1, we never milk or strip a chest tube. This could create more pressure within the patient, causing that deadly tension pneumothorax. So just think, stripping can be dangerous. This close to stripping, but never mind. Just remember, never strip or milk a chest tube. Now, the second thing is we never want to see continuous bubbling in the key term water seal or air leak chamber. The only place that should have continuous bubbling should be the suction chamber, like we're sucking bubbles. Again, think of that seal here. Remember by saying, no blowing bubbles, you seal. And lastly, number 3, never clamp during transport. Now, we talked about this before. As a general rule on the NCLEX and exams, we never clamp a chest tube. Technically, clamping is only done a few hours before chest tube removal or when we're changing that drainage device. Because clamping a chest tube. Thanks for watching. For our full video and new quiz bank, click right up here to access your free trial. And please consider subscribing to our YouTube channel. Last but not least, a big thanks.
So that was the end of the video. I followed up with it, and I was like, wait a minute, you had more to say.
Mr. Money,
Yes.
I'm gonna ask Mr. Money to get the link for this too, because, you know, as we load the presentation in PDF format, it won't let you play the video.
Certainly will.
So he'll give me the link, we'll upload that to Blackboard too, okay, so that you have access to that as well, all right? Well, what questions have you got for Mr. Money? Do y'all understand why you put the end of the chest tube down in water? Does it become disconnected from the device? And this was on your closed chest drainage system too. Water acts as a seal. For negative pressure, we can suck air through water, but there's no way for air to re-enter that space. Okay? So when we put the end of that chest tube down in that sterile water in an emergency situation where it became disconnected from the device, you're preventing air from entering that pleural space until we get it reconnected. Okay? Because again, air can't travel through water unless it's forced and pulled through. Do y'all understand why you might see intermittent bubbling, like when a patient coughs or sneezes, in our water sealed chamber, which is not gonna freak me out? Why, what's happening that might cause that random bubble? Changing the pressure in the intrathoracic space, that's exactly right. There's a random cough or a sneeze, and I see a little whoop, whatever, we'll move on. But the bubbling in that water seal, now when they first put the chest tube in, you're gonna see water bubbling in the water seal chamber, but think about what's happening. They just put it in and now they're evacuating air out. And so it's gonna pull the air out, but it should be momentary. From that point forward, you shouldn't see that anymore, okay? He did a really good job, on the presentation, so he's got some questions for you here.
All right.
Mr. Money, do you mind flipping the lights the other way?
Oh, yeah.
Turn the back ones.
Sorry about that.
No, that's fine. And then turn the front ones off. There you go. All right, y'all.
So everybody's favorite NCLEX exam questions. So a nurse has just received a report on 4 clients who all have chest tubes, which that's a rarity. Which client is the priority to see first?
C.
Everybody agree with C?
Yeah.
Sure. Yeah. So C is the correct answer. The clinical findings indicate that there is a potential air leak. All the other options are normal findings and expectations. Number 2, while helping a patient with a chest tube, while helping a patient with a chest tube repositioned in the bed, the chest tube becomes dislodged. What is your immediate nursing intervention?
B.
We're definitely not gonna reinsert it.
B is the correct answer. Reestablishing your negative pressure environment is the priority, and all the other options are incorrect. Now that A is very tempting. It really is.
It is,
You know, you're going to want to stay with your patient and monitor the vital signs until someone else arrives, but you've got a little bit of time there, so you should take care of the priority. The patient with a chest tube has no fluctuation of the water in the water sealed chamber. What could be the cause of this?
B.
So D is the correct answer. This indication suggests that a possible reinflation of the collapsed lung or an obstruction could be one of the two, and all the other options are incorrect.
Mr. Money, can I ask?
Yes, ma'am.
Okay, guys, so how would you, what assessment could you perform that might let you know which of those two it is? Do we have an obstruction or do we have re-expansion of the lung? Auscultation and inspection of your chest cavity, that's right.
if you hear bilateral breath sounds all the way to the bases, and you did not before, and time has passed, that would make my clinical judgment decide that perhaps this lung is fully inflated. Okay, chest X-ray would also help confirm that. If you have an obstruction in the system, your patient's going to start having some clinical complications. Okay? Thank you, Mr. Money, that was a great question.
The patient in room 466 calls on the call light system to tell the nurse that something is wrong with his chest tube. Upon arrival to the room, you note that the drainage system has fallen over on its side and is now leaking fluid onto the floor. A visible crack is noticed on the side of the device. So what is your next priority?
The last one.
I think I only heard like 5 people. We good? D? Okay, option D is correct. New system is needed. However, in order to maintain a water seal until the new system arrives, you will need to place the tubing 1 inch into sterile water or sterile saline to regain a water seal. I believe that video said 250 cc's, so at least that, which is not very much, but you want to make sure that you have a good coverage for your tube. 5 is the last one. You're assessing a patient who is post-op from a chest tube insertion. On assessment, you know that there's 50 cc's of serosanguinous fluid in the drainage chamber, fluctuation of the water in the water seal chamber when the patient breathes in and out, and bubbling in the suction control chamber. Which of the following is the most appropriate nursing intervention? A? So yes, A is the correct answer. All the other options on that are incorrect. I feel like it's a giveaway sometimes with the other selections. Like, there's no.
No, you did a great job. Did y'all have questions for Mr. Money regarding chest tubes? You've had several activities. You've got your, of course, your ATI closed chest drainage assignment. You've got the presentation or loaded in the course. I'm going to have Mr. Money load this presentation in the course for you along with the link for the video, okay? You can also look at some other video links. I had one that I used for years and years and years. It was really, really good, but now he requires that you pay for his services. So, it was also a very well-made job, but he did a great job, y'all.
Thank you very much.
It takes a lot of prep to prepare for class. It takes a lot of time, a lot of thought, because you can't just have a meaningless, it has to tie with your course outcomes. There's so many things to look at, is what I'm trying to say, okay? There's so much more to nursing education than you can imagine. A lot of time spent to make sure that everything is purposeful and intensive and results in what you're wanting to achieve. Now, I want to visit this sim thing for just a second. A1, did your time, on the past simulation, did your time change? A2, did yours?
No.
A3, did yours?
Yes.
How many, are you guys the group of 4?
Yeah.
Okay. A4, did yours? If you're my clinical group now, you're 4. A5 did yours. So we changed 3 and 5. What did we have you guys do in 5?
We went up to 3, because there's a, yes, we went to 8 from 2
Okay.
to 4.
All right, if Dr. Neal told y'all that, then I will honor that, okay? So, only difficulty is, like I said, it makes kind of us a little bit of a crowd, but it'll work out okay. We can work through it, okay? I don't want to negate that, because sometimes it's hard for her and I to actually collaborate on things, because we're not always here at the same time. And I know we had a discussion about this, but it's very, very, very plausible, just like I forget a lot of things that she just didn't remember that I asked not to change it for B, okay? Make sure you get with her during Module E, because she'll be presenting Module E content. I would suspect she's going to keep that same schedule for Module E, because that is a difficult, it's almost impossible to do with 4 students, okay? But visit her at that time. How many of you guys are in A5? Is there 6 of y'all or 7?
7.
Ugh. Ugh, that is tough, tough, tough. Me no like it. But we'll roll with it, okay? We'll just roll with it.
All right, guys, any questions for Module B content? Everybody okay? When is your test?
Thursday.
Y'all don't be rolling up here on Thursday, I'll have the door locked. Makeup test time. Uh-huh. Sure, y'all listen up for a second. Is it related to Module B? Okay. Module B test Thursday. I don't know if Dr. Neal is planning to start Module E afterwards. That's up to her. Does it say it on there? Yeah, but again, it's subject to change. It depends. Usually she can get through E in 6 hours that we've got dedicated to it. So I'm not anticipating that she will. As a matter of fact, I think I'm scheduled somebody a makeup test after that during that same time frame. So I don't think we don't like to do content after tests because we just don't have a choice room sometimes. Any questions between Module B before I let y'all go? Okay, don't wait till last minute to do your ATI stuff, okay? Y'all have a good day. Some of you guys didn't mark on your attendance thing at all. So